Welcome everyone to the Disaster Response Collaborative session. We're doing evacuation focus area session. We will be here for June and July, and then we'll come back together with the larger group again in August. So thank you for being here today with us. We're going to talk about leadership buy-in and business continuity. We've got some great speakers for you and wonderful breakout session later too. Before we get started, the Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. The content presented today is that of the authors and does not necessarily represent the official views of, nor an endorsement by, HRSA, HHS, or the U.S. government. For those of you seeking continuing education units, we will have those for physicians, nurses, and social work. You'll need to attend the entire live session. You'll complete the session evaluation at the end of today, at the end of the session, and then there is also a slide with a code for you to either text or go into the website and put that in. So again, we are very pleased to have you with us. Thank you for joining us. The session will be recorded, and then the slides and the recording will be posted on the website. If you have any questions at any time, feel free to throw those in the chat. We'll answer as we go along, but we'll also have a Q&A time towards the end as well. Again, we do offer MOC Part 4 for physicians, CME for the individual sessions for the physicians, as well as CEs for nurses and social workers. Do need to upload this slide. We were no longer able to provide CEs for EMTs, and we do apologize for that. As a reminder, the Pediatric Disaster Preparedness Self-Assessment for Children's Hospitals, or the PDPAC, that's that big survey that's going on right now, that is going to be extended. So if you missed the deadline to register or to submit, don't worry, we're keeping it open. We want to have as many answers and as many submissions as possible. So please, please, please complete that, register for the PDPAC. And again, that is the environmental scan for the DRC. So not only is it going to be great information to hear from children's hospitals nationally where we are as a nation on pediatric disaster preparedness, but also for your quality improvement plan and your disaster plan that you're working on in DRC, it will help there as well. So fill that out. This is our agenda today. I'm going to hand it over to Annette Newman, and she is going to tell you about that and introduce our speakers. Thank you, everybody.
Thanks, Julie. Well, welcome everybody, and thanks for joining us. I know you've probably got lots of other things that are on fire that you probably need to put out, so we're grateful that you're present with us. And we're excited to keep building on the strong momentum that we've had over the last few months. Today's session connects the dots between COOP planning and leadership engagement, which are really two critical drivers of real-world readiness, right? And so we'll take a look at the new RAPIM Evacuation Toolkit. Here's some tabletop exercise highlights, and explore strategies like Disaster Olympics to get leaders more involved. So we're excited to hear our speakers. And then we'll close today's session with the breakout discussions and share some practical ideas and opportunities as we look ahead. And thanks again for your time and expertise. So let's get started. Next slide, please. Here are what we're aiming for today. So we'll connect COOP planning like we talked about with evacuation readiness and focus on how these efforts can support hospital resilience. We'll also talk about engaging leadership and what works and what the barriers are and how to move past them. So you'll get to hear some real great world examples and some fun ideas, again, like the Disaster Olympics that can build buy-in and shift culture. We'll also have some of those tabletop takeaways. So next slide, please. Here are our speakers today. Huge thanks to Mary and Kathy for joining us. We appreciate them sharing their time. And before we go to them, let's go see to our next slide. So we wanted to kind of give you a reminder about what we've done together so far, because it's been a little while since we've been together. So we kicked off things in March, aligning around the need for pediatric specific education planning that feels realistic and usable. And staffing surfaced early as one of those things that was a critical barrier. And you guys mentioned that turnover was really constant. And so staff was really important, and that it was difficult to keep people trained and confident, especially with pediatric equipment. Leadership support was also one of the things that is mentioned. That's one of the reasons for the session today. And some groups have really strong C-suite champions, while others are kind of working hard to still get a seat at the table. In April, we dug into what makes us a strong evacuation plan, and I thought that was a particularly valuable session. We heard some really fantastic things from folks that have tested their plans, and the word nuggets came up, which I loved, and that included those color-coded roll cards, fire drill-based training, and planning variations like parental presence or partial unit evacuations. May brought us into our full group session. So that was the last session that we were in, and we reported on the big fours. And so took some of those things around staff stuff, space and systems that were all framed in that ready, set, go kind of structure, which has been a real win for the group. And then we talked about how fire drills and even mini drills can be a great staff engagement strategy, and how sometimes we need to think outside the box, which you guys have been really great in helping us see and bringing that up, especially in those breakout sessions. Staff extenders and non-traditional partners were also mentioned, and they were some of the outside the box thinking. And while we haven't gone into children and youth with special healthcare needs and behavioral health really yet, everyone agrees that it needs to have focused attention in the upcoming months. And that brings us to today's session. So it is my great honor to turn this over to Dr. Mary King, who will take us into the new hospital evacuation guide for pediatric patients. Thanks, Mary.
Thank you so much, Annette. Hello, everyone. My name is Mary King. I am a pediatric intensivist in Seattle. And I am here today to present our RAPM hospital evac guide for pediatric patients. I'm coming to you today with my own real world experience of starting a pediatric ICU in an adult pediatric trauma center. And so I also work in our pediatric medical center at Seattle Children's. And so I really span both worlds of day-to-day disaster care and some of the challenges of getting children to and from that system outside of the pediatric system, as well as being in the medical pediatric system. And how to kind of bridge those gaps between those systems. And hospital evacuation is an area that's near and dear to my heart, because many of the themes are identical to the themes that I live on the daily, trying to get pediatric patients to the right care at the right time when the systems aren't the same. So, and if you could go to the next slide. So I just want to say for my disclosure, so I am here funded through ASPR. So that is different than HHS. And so this is a project that was done with folks at RAPM funded by ASPR. Next slide. And so I'm going to start with why is pediatric evacuation different? Why does this not like other hospital evacuations? So we know this problem as pediatric providers in disaster care, that the US population is about 25% kids, but the hospital beds are, 3 to 5% pediatric. And that's even more dramatic when you look at the ICU beds for kids, for neonates and kids. And so the challenge here is if we have a disaster that affects kids and adults, we have a paucity of hospital resources. But the other issue that's very specific to evacuation is that if we have a disaster that affects kids and we have to move hospitalized kids, there are very few places that they can go because we're already at capacity. I know everybody on this call knows that and lives that on the daily, that we're over capacity. And so there are challenges if you have to evacuate an entire pediatric hospital, right? So that's going to be a regional event because you're not going to have the bed spaces to place those kids immediately available in the close vicinity. But there are also challenges if you have to evacuate a community hospital with pediatric patients. Not only is there risk of those kids not getting beds, but also that hospital itself may not be prepared to move the kids. So there's challenges for pediatric evacuation in either direction. And so today we're going to talk a little bit about both. And that's why the EVAC guide was created for both audiences, for both pediatric So you can see here we place some special emphasis on some pain points. And so things like transport, which we know is very specialized for children and is a very limited resource. So that is all in the EVAC guide. And then obviously there are many different kind of events that can trigger evacuations for all, let alone kids, and that's really no different. So next slide. So what is this guide? So this was created by, we had an evacuation work group within RAPM. And just to take a step back for those who might not know what RAPM is our Western Regional Alliance for Pediatric Emergency Management. It's one of our pediatric COEs funded through ASPR. And so this is really the COE of the West Coast and associated states nearby. So we have many pediatric experts in this group. And so many folks participated in this and provided their expert recommendations as well as literature review to provide content to this guide. So this is advice for all healthcare facilities. Really, no one is ruled out. If you have a child that presents to your facility, you may have to consider evacuation someday for that child. And so when it comes to leadership and continuity of operations, we think this guide applies for all. So it's not limited only to the pediatric hospital, although it applies. It also is intended for the community hospital. And so this is a tool that you can use for your pediatric hospitals yourselves, but this is also a tool that can be used to educate community hospitals that your pediatric hospitals may be connected with. So when you think of the hub and spoke model, we created this guide for both parts of that model. And then also it helps create a common language and infrastructure. So we have some key tools that are part of this guide. So we've included train triage as one example. Pediatric levels of care, we think it's really important to talk about common definitions. One very novel piece is a kind of a new HICS role that we're suggesting. It's an old role that we're putting a pediatric spin on, and I'm going to show you a picture of that in just a moment. And then we've created HICS job action sheets around this new role. So really what we're doing is taking the medical tech specialists that exists within HICS just in general, and we're applying a pediatric name to that role. So a pediatric med tech specialist. And we're recommending that to be involved in HICS for any hospital that admits children at all, because there needs to be pediatric leadership at the table when it comes to hospital evacuation. There are too many opportunities for failure. And that just, that's where we need to start the conversation. So if you're going to take home one thing from this to your leadership, to your C-suite, it's going to be this piece. I'm going to show you a picture of this. But we have job action sheets to support that. We also have additional resources like checklists, supply cache guidances, family tracking templates, and more. Next slide, please. So we structure the evac guide around 4 stages of evacuation. So pre-evacuation, evacuation, post-evacuation, and recovery. So this really is about continuity of operations. And so, for folks that are really trying to use this guide, they can go through this both sequentially in terms of real time when they're responding to an evacuation, or in preparation and preparedness efforts as well. So you can see for pre-evac, we've gone through and defined triggers, transport and bed matching. We spend a lot of time on transport and bed allocation because those are specific pediatric pain points, as well as family contacts that are specific to kids. Then during evacuation, we talk about asset coordination, developmental safety, and tracking details having to do with kids. And then post-evac, there's a lot of focus on reunification, verifying placements, and mental health. And then recovery are your more general lessons learned and repatriation. Next slide. So this is one of the take-home points that I hope you get from today is, where does pediatrics fit into HICS when it comes to hospital evacuation? I would like you to look at this little red box. I know it's small, but to me, it's very important. And this is having a pediatric seat at the table. I find in a lot of large events, what can happen, even with folks that are well-informed, is if you don't have the right expertise at the table, you can't identify your pain points. You can't identify opportunities for failure. And so this pediatric med tech specialist, this is not a new role that we're defining. The med tech specialist has always been within HICS, but we are recommending that you designate a pediatric med tech specialist specifically, and that for hospital evacuation, there should always be one engaged at HICS. And this is true whether it's HICS at the hospital level or even regional response. If you have an interagency group that is responding and coordinating evacuation, there should be a pediatric med tech specialist engaged at that level as well. So beneath them, down below under operations, you can see we've incorporated NICU and PICU critical care team leaders, and those are further down. Those are the same type of folks that may be someone that might serve in this medical tech, med tech specialist role. It's someone who understands pediatric transport, critical care, and safety for kids. So it depends on the hospital. At a big pediatric center, it might be a critical care doc or an emergency medicine doc or even a hospitalist with a lot of experience. And then in a community hospital, it's going to be someone with the most pediatric expertise that also can take care of sicker kids. And then we've included job action sheets for all of these examples. Next slide. So here is just, here's a resource for you. So this is a QR code that you can go and scan right now if you want, or from the slides later. You can go ahead and download the guide from our RAPM portal directly. It's open access. It was put up there about a month and a half ago. And so we welcome all to engage with this product, and we welcome feedback as well. So we're excited to get this out there. We're especially excited to get it out there before next, for lack of a better term, evacuation season. Next slide. So I just want to say before I stop for questions and discussions, just a big thank you to all of my colleagues within RAPM. There are many, many folks who have contributed to this. So you'll see when you download this in the beginning, we have our contributors there listed. David McCarthy and Chris McCarthy were both really big key editors for this project with me. And so I can't thank them all enough, and the leadership at RAPM for supporting this work. So I'm going to stop there and see, Annette, if we have any questions from the group that we should field at this point. Thank you so much.
That was fantastic. What questions do you have for Mary? She comes from a unique position of both PEDS hospital and adult with PEDS unit. So I know there are several of you that also have that same situation. While you're warming up, I'll ask Mary a question. Mary, if there was one pearl, one nugget, one thing you could tell the folks on the evacuation DRC, that would be vitally important that they could not do, what would it be?
Aside from assigning a pediatric medical tech specialist to Hicks, which I think I hammered home, I really think it's about building relationships. And so having folks in those leadership spots that already have relationships with both the disaster infrastructure and leadership infrastructure of your hospital, as well as with your regional infrastructure. Because I think you need to have this like multiple way dialogue. I think in pediatrics, we're unfortunately siloed more than we should be. And so I have the opportunity working at a larger adult peds trauma center to see that difference. And so I think it's critically important to have someone that has the relationships. And I'd also add to that relationships with EMS. So with the regional interagency groups, with EMS, and with hospital leadership. So I think all of those are critical. And I think even more critical in pediatrics where we're just not as quite as connected.
Yeah, I love that. It was just on a Mercy all morning with one of our biggest coalitions, and we did a segment on patient movement and the importance of transportation relationships was huge and was very evident on our Mercy this morning. So yeah, I second everything you said. Those community partners are really important.
Yeah. I agree. I think my other experience with that is when we created the WMCC in Washington, those relationships that led to that mock being created, those relationships existed for years prior. And so there was nothing new being created de novo. And so the work that we do in preparedness and building those relationships is pays dividends when it comes to event response. And so anything we can do to encourage our leadership to understand that piece and encourage that participation and to be knowledgeable about, and informed and engaged, I think is also a really key piece.
All right, last chance. This is your opportunity to quiz Dr. Mary King. Come on, people. You know you have questions for her.
I think one question I have for the group, and that's just, my hope is that folks can download this and take this back to their hospital and let us know kind of what you guys are seeing with this. We're hoping at some point that we'll have the opportunity to test this. And so, but even before we do that, please provide us feedback. My email's here. Feel free to reach out. You guys also know a lot of the folks at RAPM as well. So reach out to any of us to let us know if this is helpful and what you guys are seeing and thinking. So thank you so much for having me here today.
Annette, we need to make sure we have this on the website, the link for it on the website.
I put
Absolutely.
it in the chat. This resource will be posted to the website, and it will also be in the follow-up message next week.
I do see one question here from Colin Clark. I guess I would like a little bit more clarity on the question. Are you talking about a report after an after action report? I'm just not sure exactly.
Oh, no, I'm sorry. Hi, I'm Colin Clark. I'm a pediatric emergency physician from Columbus, Ohio at Nationwide Children's Hospital. So yeah, my question is, I think that we have a really good relationship with our regional trauma system as well as a lot of hospitals in the region. But when I'm thinking about once we've established this rapport and like we know of each other and we're willing to collaborate, I worry that if I come to my external partners with like this huge ask of like, okay, say we have to emergently evacuate the children's hospital, how many pediatric patients can you take in the next 12 hours? They'll be like, they'll shut down. They're like, nope. So I wonder, like, how do you sort of introduce that concept? How do you, what recommendations would you have to really sort of ease our external partners into that concept so that we can, not overwhelm them, but at the same time encourage them to participate and say like, hey, this is a reasonable goal if we can, take it stepwise.
Got it. Okay. Now I'm understanding rapport, not reports. So that's a great question. And I think this comes down to building day-to-day resiliency in systems. And fortunately, I get to work with a lot of community partners regularly. And so instead of necessarily planning for the, huge event, it is much more common that they're going to receive, a car accident or something like that. And so building the resiliency into the system to imagine a smaller event and even potentially to tabletop that. But I see this as a plan that really can be adapted to the community hospital for moving just even from their end, because what they're going to have a vested interest in is if they have a couple, a few kids that they have to move, how are they going to do that? Those pearls are in this guide. And so I would start there. Because I think it's a little bit of a tit for tat. Like you're thinking about, well, how can you help me with our, huge hospital that we have to evacuate? But for them, it's just a matter of, okay, we have a few patients, pediatric patients, and we have no idea what the transport risks are, how we would move them in our hospital or where we would send them. So I see that as a two-way street conversation. And so the more that we can get them engaged in preparing on their end, the more resilient and able they will be. And those relationships will also be there to help reciprocate the help. And so I do think that starting with chunks is the way to go. And I think that's true for a pediatric surge in general, let alone the evacuation piece. And so again, back to the day-to-day resiliency piece. Does that answer your question, Colin? Looks like he's off. It looks like Tanya has her hand raised.
Yeah, no, thank you. Quick question. We are in the process of looking at, number one, we realize that our pediatric floor does not have an evacuation policy. So we're working on writing one. because that's helpful, right? We do have one for our NICU, we do have one for labor and delivery, we do have for mother baby, but we just don't have one for the pediatric care areas, which is PICU and pediatrics, the regular floor. What we're finding is that, again, we want to make sure that we get all of the elements that we need within the policy, but we also are thinking that where we're going to start is looking at that horizontal evacuation piece, because again, we've never historically practiced it. And that's something that we think is a good starting place. Plus, a really smart person who is well-versed in emergency management said that if we could do that successfully, we should have success doing most anything. So I think that that's our plan, and we're hoping that within the RAPM documentation, there's some guidance on that, because I know that right now we have a tendency to fall down rabbit holes when we start to plan and we get to the big picture of, okay, so now that we're talking evacuation horizontally, then we get into, well, let's talk vertically and let's talk completely out. And it's like, wait a minute, let's pump the brakes and do the horizontal really good so that we can kind of get to where we need to be for the rest.
Yeah, no, I think that's a really important point. And we do have some areas in the evac guide on specifics of pediatric transport and whether it's intra-hospital or extra-hospital movement. And I do think that just, going through the process of drilling it with your team makes it seem a lot less like a black box. I think there's just a lot of fear around it. And I think also what you're pointing out is pediatrics kind of being left out is really common at non-pediatric only hospitals. So what you're describing is not unique. And so you can totally normalize it and be like, hey, this is something we know we need to address, and here are some first steps we could take. And I think, like you just identified, horizontal evacuation is a perfect place to start. And I think, there's a lot of tools in the toolkit, and I think making sure that you also have the pediatric leaders that are part of the evacuation planning process in general is going to be another kind of key item to make your process successful. So that's awesome to hear that.
All right. It looks like it's time to move on. I know we've got kind of a tight agenda, but I want to give a huge shout out to Mary. You guys all have her email address, and I've got her cell number that I just barely got right before this that I'm happy to share for a price. No, I'm just kidding. You now know how to get a hold of Mary on her email, so please reach out if you have additional questions. I'm sure she'd be delighted to get back to you and share more. So she'll also be staying with us for the breakout sessions. So if you're lucky enough to get into Mary's group, then you can continue to ask her questions. Anyway, the RAPM evacuation playbook gave us a really great framework for building continuity plans that really help us maintain operations during disruption, right? So, but planning is really only step one. The bigger question is, how do we operationalize it when the real pressure hits? So next slide, please. I personally love this slide. It's an old NIH 2009 slide, but it reminds us that even on a blue sky day, care rapidly shifts across conventional contingency and crisis tiers. And sometimes in pediatrics, we're already at the tipping point and it's just a blue sky day. So that's why leadership buy-in isn't optional. It really is essential. The C-suite has the power to allocate resources, empower staff, and really reinforce systems that keep us from slipping or staying in crisis, again, even on a blue sky day. So how do we move from having a playbook that Mary has just talked through to actually playing the game? And that's where innovative engagement strategies like the Disaster Olympics, which are coming up next, can turn leadership into really active partners, not just passive supporters. So next slide, please. As we shift from that visual, right, that conventional to crisis, this slide really focuses on what leadership actually needs to do. I'm definitely not going to go through each one of these bullet points. These are actually not aspirational goals. They're practical leadership actions pulled directly from our group discussions, and from prioritizing COOP integration to backing scalable staffing and into facility support. They're real tangible ways that leaders can prepare teams to navigate surge and escalation. The truth is, really, no matter how strong your plan is on paper, execution in a disaster hinges on leadership behavior. So do they delegate authority to those closest to the bedside? Do they support just-in-time training? Do they really recognize when care is slipping into contingency? And that's a huge one. I know that's talked about a lot in our state. And perhaps more importantly, do they send the message that planning for crisis isn't about panic of failure? It's about stewardship, safety, and smart resource use, which is really important. And one great example that we have of turning those ideas into action is what Kathy and her team created, which is the Disaster Olympics. It's a really fun and interactive way to engage our leadership. And so I'd like to turn the time over to Kathy so that she can show us what she's got. Thanks, Kathy.
All right. Well, thanks, Annette. So yes, I am Kathy Lehman-Huskamp, very long hyphenated last name. I'm at the Medical University of South Carolina. Next slide. Oh, okay. That's in Charleston, South Carolina. My Charleston slide is gone. And so I am a pediatric ER doc. And my career path was I did my pediatric residency and PEM fellowship in St. Louis, Missouri. While I was there, I started getting into disaster medicine during my fellowship. It rapidly escalated is really all I can say. People, as a physician, since I was interested, they were very hungry to have a physician that was interested. So it worked out well for me. Before I left St. Louis, I was actually on a supervisory emergency management committee over 7 SSM St. Louis hospitals. In 2012, I moved to Charleston, South Carolina, and quickly became their medical director of emergency management. And by 2014, I was actually their administrative director of emergency preparedness and planning. So how does one get there? Next slide. Okay. I hope you can read this okay. The long and short is Ebola got me there. My hospital went into full, I wouldn't say panic, but a definite desire to be able to treat those types of patients. I was actually in Disney World with my family when that happened, and my phone started blowing up, and it was like, when are you getting back? And so that was a whirlwind of planning and preparation. I do believe that emergency management is best to actually help with that high-risk infectious disease, but that's a whole nother discussion. And so what this got me is, get ready for this, a 55% buy down. I worked 6 shifts a month. My boss or direct report was the chief operating officer of the hospital. I had 1 direct report under me and 2 dotted lines. I had 2 cost centers, 2 budgets. I was the deputy incident commander for multiple hurricanes, 1,000-year flood, snowstorms, because when we have snowstorm in Charleston, we shut down, and a mass casualty, which involved a hate crime at one of our local churches. And so it was a whirlwind. And I will say, if you get an opportunity like that, it is one of the best things that can possibly happen to you. And sometimes it's one of the worst things that can absolutely happen to you. Because I went quickly to working 60 to 80-hour weeks all the time. Everybody had my cell phone number, and that's the way I wanted it. But there just were times of making that accessibility is a little bit of a curse. So for me in 2019, hold on, rewind. So at that time, I was over 1 entire campus. So that involved a adult hospital, a pediatric hospital, and a psychiatric hospital that had both inpatient adults and kids. In 2019, my organization decided they wanted to go corporate. And since then, they have gone from one campus to, I believe it's 25 plus now. And they wanted me to be their corporate hospital emergency manager. There was going to be more buy down. There probably was going to be a high title change. But for me, I decided that was my time to gracefully bow out. I was getting ready to be chair of the disaster section of ASAP, and I basically felt like I was drowning with one nostril out constantly. So, and this is somebody who really loves hospital emergency management. So probably one of the hardest decisions in my life. So my advice is, if you get the opportunity, please, I strongly believe in physicians and nursing being in these roles. And just what Mary was saying, I can't even tell you how many times I had to remind people what it meant to be a child in all of these events and in drills. So many times the adult emergency department, I know, great, you want to keep the families together, but you do need to let the pediatric ER play as well. Just so many things like that. But now I get to do things like this with big organizations. So it has been a sweet spot for me. So let's talk about some fun ways to do education. Next slide. Okay, so everybody knows that, I would say we all know that education is one of the hardest things in healthcare these days. How do you take your plan and actually educate it so people know about it and it makes sense? We talked about taking advantage of fire drills. I would just throw in, also take advantage of online mandatory training. And so that often includes fire. So if you can convince those folks to let you have a slide or two pertaining to evacuation, like let's take fire a little bit further, that's an easy way to convince people to let you throw in some education training. The other thing is for folks who do emergency management rounding to go to a unit and say, okay, we're going to do a mini drill. This event has happened. Who would you evacuate first? And just make them do a priority list of who they would get out. It's little things like that that you can incorporate into more everyday things or annual requirements. Now, however, at MUSC, we really took the September National Preparedness Month and ran with it. And so in that month, we would have a disaster fair, disaster Olympics, and a disaster Jeopardy tournament. Next slide. So at a disaster fair, basically, we just reached out to a bunch of different organizations, Red Cross, National Weather Service. We would bring in one of Charleston's favorite meteorologists, hazmat teams, city, county emergency management, have them set up tables, pass out information. We would also do raffle and have t-shirts and fun prizes. And so it really, and food trucks, you got to have food. And so it just really got to be where people were out there and having fun, but learning. Next slide. The Disaster Olympics was often the day either before or after the disaster fair. So everybody was kind of excited. And we let groups throughout the campus. So any unit who wanted to make a team could make a team, or residents could make a team. And we had several different categories and they would compete. So in regards to evacuation, it was a great time to bring out different evacuation equipment. For the triage, you could do it for mass casualty, but you also could do it for evacuating what kids are going to go first. I love the picture. That was with the PPE. We would make them put PPE on, following a list, and then make them do something like put a puzzle together to show them the dexterity issues with PPE. But there was just like a bunch of fun things, and they loved it. Next slide. And last but not least, this is actually the pediatric residents. We would have a disaster Jeopardy tournament. I learned the incredible competitiveness of pediatric residents, but they very much enjoyed it. It was a lot of fun. Next slide. And that's, we went all out. There's our referees, including myself. Thank you. Any questions?
I love that picture. That's a great picture.
We had penalty flags. We used them.
That's awesome. Any questions from anyone for Kathy? I know we have the Olympics coming up, and so I think that this will be a great tie-in for Utah for the 2034 Olympics. Mary.
I was just going to comment. It's just interesting. So what we've done to increase education and buy-in from leaders is even we've used the disaster jeopardy kind of structure for like critical care advisory committee meeting at Harborview Medical Center, just so people know where do you respond if you're this role and whatever it is. But this structure of using the jeopardy can be applied to a lot of different settings, not just even educating the residents. So I love it that you're incorporating it here.
Well, and what's interesting, I meant to say this on my slides, having the bigger things like a big tournament or fair or Olympics, obviously you're only educating a smaller group at that point. But what it does for the psyche of the staff when they see these big events and it's all in the name of disaster preparedness, they get the sense of we are prepared. And sometimes you need that as well.
Yeah, and I just think it feels more approachable in kind of that setting. And so it's interesting how to teach disaster medicine, for us on this call, we kind of live this on the daily, but for folks who don't as much, just making it more approachable seems like a common theme. So I love seeing all this. Thanks.
Oh, we've got some great questions coming in the chat about would you be willing to share your Jeopardy questions and content so we replicate. Be great to have a starting block, and we'll see if we can get some of those from Kathy, and maybe if there are others. I know Mary just mentioned that it was a good way to add to meetings too, as we think about those easy nuggets that don't take a lot of time and definitely don't take a lot of money. This is a really great way to kind of pull it all together, but we will try and get a hold of all of that stuff and share those with folks on the call. I'm just reading through to make sure I haven't missed anything. Oh, there's a question from Regina. How did you drum up engagement for this? And she said, I'm sure you advertised it ahead of time, etc. But how did you rally? How did you, cheerlead?
Well, we definitely advertised it. After the first year, quite honestly, it was easy because people remembered it and they enjoyed it and they wanted to participate. Before that, we have different manager group meetings and leadership meetings that we pushed it out through there. We have a emergency management website that's in the intranet. It's not public, and we would put things up there. And then essentially, then people would reach out to us about wanting to form a team. The first year I was actually creating campus-wide department emergency resource guides that were based on the type of unit you were. And so I was meeting with all the managers over and over and over again. And so I had a lot of relationship building that way as well. So honestly, it was pretty easy because of how much I was in their everyday life to drum up support for the teams. The residents, all you had to do was say, I'm going to give candy and free pizza and have a tournament, and they were there.
I think what it really does is say a lot about Kathy, because Kathy is fantastic, and I think you probably were just an incredible leader, Kathy, so people wanted to follow you, and this is a great way to do it. Well, we are going to move on. I don't see any more questions in chat, and we still have a tabletop exercise and breakout sessions and then a report out. So let us do a poll question. So Julie, if you want to go back to, I think it's the slide previous to this one. So this is about what best describes your hospital C-suite and high-level leadership engagement in disaster preparation. And if you could select all that apply, that would be awesome. And then that way we have some data around who has that. Is there any kind of nuances that the folks need, Julie, behind the data collection for the slide?
I put the link in the chat. You can also join by text and send the letters EMSC to the number 22333. And it should let you put your answers in.
I'm trying it too. We getting anyone coming through, Julie?
Yes.
This is great, you guys. This is such a testament to not only you being on here, but to your leadership support as well. All of you, there's not, it doesn't look like there's anyone that has said not sure or unknown or typically only involved during an actual disaster. So that's really heartwarming, to be honest with you. Thank you, everyone. Let us maybe move to the next slide, Julie. So this, I think it's tabletop exercises, Julie, after this. Fantastic. We would love to invite Jack Smith, who's the director of the Office of Emergency Management from Nationwide Children's, to share a little bit about his experience with their tabletop exercise. Jack, do you want to unmute and let folks know how your tabletop went, and maybe you can chat about engagement of your leadership too.
Actually, we used our tabletop, basically just our OEM staff and medical directors and ED folks, because we really wanted to focus on some of the implementation details. So really, we started our process early on. So we're in the middle of building a new 14-story tower, and our hospital is pediatric only. It's about 460 beds. And so we really started with reimagining and looking at, hey, do we have the right evacuation devices for our patient population? And so did a pretty comprehensive evaluation of most of the devices on the market to see, what is the most effective for, staff members. Some devices take 2 staff members to move a patient, some take 1. If you're talking about NICU babies, you can maybe carry two or more, depending on the device. And so really looking at what is the safest for the staff, what's safest for the patient, what from a process standpoint, what's the most manpower or staff efficient, and looking at that from top to bottom, as well as, okay, if we are going vertical at that point, have we identified both horizontally and vertical where those locations are? If those patients are on oxygen, do they have wall hookups for the next evacuation location, or do we need to include splitters or room air blenders or whatever, depending on where that that evacuation location is. And then if we get downstairs, where are we staging the patients? If we do not have enough evacuation devices for each patient. So is it practical to consider that everybody's going to be running back upstairs with empty devices to bring down more patients if we've lost the elevators? So kind of doing a work process analysis with, how long is that going to work before you've exhausted all of your staff members, and then where are we staging the patients? Do we need to look at cots, which we have plenty of, or foam mattresses or whatever, because most of these evacuation devices don't include the mattress from the bed. So if you've left the patient on the hard floor in the lobby waiting for transportation resources for offsite evacuation, and so really trying to drill down into some of those details. And we don't have all those answers yet. We're still in the middle of that planning and putting that together. But the plan is that as we tabletop this and workshop it from a planning standpoint, and then do some small drills, kind of building into a full-scale exercise. So then in about a year, when the new tower is done, and as we populate that new tower, we can do that as an evacuation exercise. So it's kind of our global plan, and really trying to drill into the implementation details so that we've got all of those things ironed out.
That's awesome, Jack. If you could choose your most favorite nugget, bringing back that nugget word, what would it be?
I think it's really, if you're looking kind of through the lens of the high reliability healthcare model, and having that questioning mindset is, when you look at something, look at it with a little bit of pessimism or open-mindedness to say, is this, the plan looks good on paper, but have we really exercised it and worked out all of those little bugs? Because something can look good on paper, but if it doesn't necessarily work in the real world, then it's really not that valuable. So I guess the nugget would be, you can plan all day long, but until you actually start drilling it and exercising it in full scale, you're really not going to have stressed the system to find the weak links in it.
Great. Thanks, Jack. Those are some wise words. Make me think of Mike Tyson's, everyone has a plan until they're punched in the face. And that's a great way to learn that. Well, let us move to one of my favorite parts, which is our breakout sessions. And I know since we went long on that very first session, now I'm kind of OCD about staying on time, and we've only got 15 minutes left. So we will get you out of here on time, but it will shorten our breakouts just a little. So I think we have, 3 different breakouts, Julie? So let us move into breakouts, and you might want to take a picture of this on your phones, because this is what we're going to talk about in breakouts. And then that way, at least you have the questions. So great. And then if people want to share in chat while you're finishing up, Julie, that would be perfect too.
Yes, please. You want to let you know where we are as far as within the DRC. You should be working on the PD pack, which is also the environmental scan for DRC. So we have extended that. So the deadline was not May 31st. You still have time. So please, please, please complete that PD pack. We also, if you have completed your tabletop exercise, whether virtually or hospital led, you should have received a data collection survey. This one's really, really short, especially compared to PD pack. But and you would have gotten that from the dnc.ppn@austin.utexas.edu email within the last 2 weeks. So once you have completed all of your tabletop exercises, this is letting us know where things you learned, your aha moments, some barriers, a lot of what Jack told us about. And then upcoming, if you have not done your TTX, yet. There are a few available sessions left. So for evacuation, there is a session on June 12th from 1 to 4 Central Time. If you want to squeeze that in, if you can get everybody scheduled from your hospital, email the DNC PPN website as soon as possible so that we can get everything ready and all your materials, and we can get you into that session. We have some DRC upcoming sessions on July 1st, so we'll meet first Tuesday of next month, same place, same time, same group of people. So we're going to be meeting with the evacuation focus group again, and it will be the same link, Zoom link you used today. So you can go ahead and you registered for June and July at the same time. As far as August, again, we'll come back together as all 4 focus groups together and learn from each other. And we're going to actually hear from other people about their tabletop exercises, much like what Jack did today for us. We're going to hear more about individual tabletop exercises. But you can register here at that QR code as well. We have a PPN webinar coming up. PPN hosted webinar coming up. This is on the pediatric crisis standards of care and a legal webinar talking about legality. We'll put that in the chat for you. It's Wednesday, June 11th. From 2 to 3:30 p.m. Notice that it's Eastern time. We usually post things in Central time. For some reason, our webinars today are being advertised in Eastern time. So just notice that change, but it is next Wednesday, June 11th. And you can register for the QR code or the link I put in the chat. We also have an echo series coming up from the Disaster Mental Health group, talking about preparedness and response to catastrophic events. If you've never done an echo series, they're really fun. They're similar to the collaboratives, but the echo series, what happens is they'll talk about different topics each session. There's going to be 6 different sessions for about an hour. And then you'll have the first part will be didactic. And then the last part, they'll give you a case discussion and you discuss that as a group. So here are the dates and the time. Again, the time is in Eastern, but you can register at that QR code. Or the link I just put in the chat. Finally, we have our evaluation and continuing education links. You'll see here, for those of you that do want continuing education, your code is DUSVUY. You can text that, or you can go to the website and put that in. In order to get that, you will also need to do the evaluation. Interesting. So you can evaluation, I'll put the link in the chat for you there, or you can use that QR code right there. Once you open up that evaluation, you are free to close your browser for the Zoom meeting and move on with your day. Enjoy your day. Thank you for being with us. We're very excited to have you. Lots of engagement, lots of nuggets today, and we'll be sharing everything. So we'll share the resource, the evacuation resource. We will reach out to Kathy about sharing those Jeopardy questions. And that should have given everybody enough time to get that evaluation survey. If you would like to stick around and talk about your breakout sessions, we'll be happy to stick around for a few minutes.